Hello, and thank you for joining us. My name is Brian Zimmerman, and I will be your moderator for this session. Before we get into some introductions for this great group from Texas Health Fort Worth, I'd like to start with some tips to participate in this session. Please use the Q&A box to enter your questions for the speakers. We will address those as they come in, and our panelists will tackle a couple at the end of our session. To engage with your fellow attendees, please use the group chat feature. If you experience any technical issues, please email support@mig.cc for assistance. Now let's begin. So as operating rooms and hospitals in general mature in their adoption of new technologies, the complexities of multiple manufacturers and systems designs can become daunting in the delivery of care. These complexities can expand to affect how these investments perform toward a hospital's strategic, clinical, and patient care goals. Integrating a cohesive suite of complementary technology platforms may serve as a more than tools working with each other. If planned for accordingly, standardized technologies may serve to accelerate a hospital's quad aim strategies. So we've got a great group. As I mentioned, we're going to get started with some 20-second intros. Joseph, why don't you kick us off with that?
Hey, Brian, thank you very much for having us. I'm Joseph DeLeon, the president of Texas Health Harris Methodist Hospital in Fort Worth. And we are excited to share with you our experience. You hit the nail on the head. You explained the journey that we are all on and the challenges that come with it.
Joseph, thank you for being here. And it's great to have the whole group. Jennifer, why don't you go next?
Hello, thanks for having us today. My name is Jennifer Chavez. I'm the Vice President of Professional Services at Texas Health Harris Methodist Hospital in Fort Worth. And again, we're excited to be part of this.
Yeah, thank you, Jennifer. Dr. Burk, why don't you go next?
I'm John Burk. I work in pulmonary disease and have for some 4 decades. It's been exciting to work in interventional pulmonary and lung cancer detection and diagnosis and treatment in the program at Harris Methodist Fort Worth. I couldn't imagine doing this when starting practice, but the last couple of years, this program has been dreamed of, it's been initiated, it's functioning, and we are doing things we never dreamed of before. These are exciting times at Harris Methodist.
Excellent. Thank you for being here, Dr. Burk. Dr. Vigness, why don't you go next?
Thank you also for including us in this discussion. I'm Richard Vigness. I'm a cardiothoracic and vascular surgeon. I've been practicing at Texas Health Fort Worth for over 30 years, and we're very excited to embrace this suite of technology for the care of our patients.
All right. Thank you so much, Dr. Vigness. And let's really dig in here. So, Joseph, I'm going to begin with you. Can you sort of start us off with maybe talk about what problem you were hoping to solve when Texas Health began down the road of standardizing the robotic systems in terms of a strategic initiative? What were you really getting after?
Yes, there are a number of challenges, and you covered some of them in the introduction, but what we found ourselves looking to solve are problems or challenges related to patient satisfaction, to clinical outcomes that exceeded the patient's expectations. We were looking to utilize technology in a way that helped us to be able to address numerous service lines where we still had application of techniques that used an open approach versus a minimally invasive approach like the Vinci as part of the intuitive suite. And so as we look to try to close some gaps in both quality and efficiency, our experience with intuitive and Da Vinci for many years to date has really helped us to be able to tackle those successfully. And as we identify partners like Drs. Burk and Vigness, we have been able to successfully close some of those gaps.
Appreciate that, Joseph. Jennifer, I want to turn to you next. And you know, when we talk about standardization, you know, the thought of operational gains and inventory consolidation, for example, really come to mind. Can you talk about from an operational point of view, what have you experienced? What have you seen so far?
Sure. I'm going to ask the physician partners towards the end of this to chime in as well, as they are a huge portion of overall operational efficiencies and gains. Overall, competency and training has been much more succinct. We are able to train our staff, so we are able to perform robotics 24/7 currently at our hospital in Texas Health Fort Worth. Additionally, it allows for unfettered access and efficiencies with turnover times and first case on time starts, which improves overall just operational efficiencies every day.
Thank you for sharing that, Jennifer. Dr. Vigness and Dr. Burk, I want to turn to you now and maybe get so attendees can sort of understand from your perspective how the lack of standardization really affected patient care and your delivery of care. Dr. Burk, why don't we begin with you?
Without standardization, we actually had some missteps, some competing interest, as we recognize the opportunity to come together in patient care, to come together in the planning of cases, to come together in the operation of that patient, be it diagnostically with ion bronchoscopy or in the operating room with Da Vinci. The whole team has come together and relaxed and worked and learned about each other and what they could do and what they could offer in ways we did not imagine before.
Yep. Dr. Vigness, how about you? Can you talk about how the lack of standardization affected the delivery of patient care?
Well, sure. It was very haphazard. Being a community that really has a high level of care, it was difficult to get all of the pieces together in the puzzle at the same time. And using uniform technology, which we have in the hospital, and as Dr. Burk mentioned, getting all the people on the same page in our virtual clinic so that our information is unified, we're able to much more quickly get to a therapeutic opportunity. It's key that we have 4 XI machines that are active. All of these XI machines are within about 50 feet of each other. And so, as Jennifer mentioned, we have trained the staff so that those machines can be active really at any time. And so access to the technology is not a problem. We have excellent technology and excellent staff to support it. We work on the things every day. Every time we finish a case, we have a rap sheet, we call it, such that things that we ask for that somebody had to go get. Well, let's have that in the room, the next time. Let's put that on the rap sheet. We don't have to fuss at anybody. We just see it as an opportunity for improvement. And so as a result, it's really quite fun for the staff to be in there because they're very excited about doing robotics. And because the hospital is so robust in supporting it from an equipment standpoint, we are never lacking. These suite of XI machines are centered around our surgical pathology department. So we're always just steps away from getting an intraoperative biopsy result. And we're really honing this into quite a slick machine.
I want to drill down there a little bit more on the technology here. Can you talk more about what the combination of Intuitive's 4th generation Da Vinci systems with their Ion system has meant for patient care? Can you share even more about that, Dr. Vigness? We'll start with you, and Dr. Burk, I want to hear from you as well.
Oh, it's been huge. Ion is a great technology, and John has mastered it. John and I have been working on this program, hoping that it would come for the last 30 years. And so now that Ion and the 4th generation Da Vinci are here, we can pretty much offer a patient a diagnosis and a therapeutic resection all under the same anesthetic. We have our, as I mentioned, we have our surgical pathology partners that are right next door. And so we work with them. And we have this strong clinical suspicion that somebody might have a resectable lung cancer. We have this virtual clinic that's put together all the information so that we don't have anything lacking in terms of meeting any quality metrics that somebody would want to imagine and following the latest guidelines. And then we have the diagnosis, the biopsy, the ion biopsy. And then we have the surgical intervention, all under the same anesthetic. It's great.
Thank you for sharing that, Dr. Vigness. Dr. Burk, any hook-ons there to your colleagues' comments?
patients are most appreciative of that approach, but the patients are highly selected. The patients have been screened to say, is this an appropriate mode of therapy to offer to them? Early on, we kind of thought, well, we'd move the Ion down to the Da Vinci, and the learning experience was maybe that's not the best idea. So the endoscopy suite is 1 floor away from the operating room. We have a basically dedicated room in endoscopy for Ions. We do the procedure there. There's a private elevator that connects the 2 floors, and the patient with a positive diagnosis can roll down, be on the Da Vinci, and Richard completes the procedure. Get to see him that afternoon as they're upstairs on the floor, as they get the tube out the next day. Been remarkable to think that you can take through an evaluation, a workup, diagnosis, and treatment in a matter of, at this point, we can say weeks from that initial referral. We hope to see that get even less as time goes by for these highly selected cases.
Really impressive. I really appreciate you sharing with our attendees the work you and your colleagues are doing. Thank you both, Dr. Vigness and Dr. Burk, for that. Joseph, I want to turn to you next. So we've just heard from your docs here about how the combination of Ion and Da Vinci XI has really allowed, this ability to deliver single anesthesia events to some of their patients. Can you talk about, from like a strategic perspective, how this combined capability has sort of supported your patient strategies, I guess, overall?
Yeah, thank you. Listening to these 2 physicians talk about the experience of the patient as many times as I have, I'm always excited to hear the patient's journey has been improved. The patient's complication exposure has been reduced. The patient's experience has been improved tremendously. I mean, we think about the way that care had been provided in this community, as Dr. Vigness pointed out. It spanned a long time, often many, many months. And to have the ability to integrate all of those pieces in such a short time frame has really begun to evoke a response from the community, from the medical community, and as it becomes more and more widely known, we are hearing more and more new physicians, new patients who had not experienced our healthcare system before even enter into the system for this service. And so the patient outcomes, the cost of care, the reduction in infections, the reduction of stress to the patient, who historically would have had to traverse this journey, all have been improved because of the teamwork that we've been able to accomplish here. I was rounding in a unit not too long ago and ran into Dr. Burk, and he summed it up in one statement. He said, our team has transformed lung cancer care in Fort Worth, and that is all the satisfaction, and that meets the goals of what we've been attempting to accomplish by putting all of these pieces of technology, but mostly of the expertise of the physicians and the staff here at Texas Health Fort Worth.
Thank you so much, Joseph. And I think what you talked about really is, this program really hitting on all those 4 components of the quadruple aim as well, sort of touching on all those different experiences. Jennifer, I got a follow up for you then, sort of on this same point. After sort of considering and thinking about the way this changes patient care and perhaps other patient care strategies, how has Texas Health Fort Worth really leveraged these complementary technologies and teams toward achieving other aims?
Sure. So with the Ion and the Da Vinci technology, we've vetted through marketing a way to look more strategically at growing our overall thoracic program. We at Texas Health Fort Worth take care of a very high acuity patient demographic, as well as using these minimally invasive robotic therapies. We're able to get patients out quicker. And so not only are we able to leverage the appropriate technology, which drives quality and patient outcomes, as well as patient satisfaction, we're also able to help support market capture for these advanced technologies. Additionally, with these technologies, it helps us leverage other surgeon pathways for colorectal and hernia surgeries to be an overarching center of excellence.
Thank you, Jennifer. Important points there too. I want to turn back to our physicians, though. I want to get down to really talking about any other clinical optimization that comes along with standardized systems to the XI. So Dr. Vigness, perhaps you can kick us off on that. Can you talk about clinical optimization that comes along with this technology?
Sure. As Jennifer mentioned, there's lots of service lines that are expanding their robotic applications. And we oftentimes will share instruments, the same instruments as these other surgeons. And so with this suite of 4XI machines that are in the same physical location, all of our supplies are right there. And we share a lot of these instruments. We advance together with our colorectal colleagues and our general surgery colleagues as they develop their skills. And our staff are all sort of unified in terms of approaching it. And so as a result, well, our gynecologists have really sort of led the activity. They're very prominent in what we do. And so we're all sort of advancing together, and we all sort of are using the same machines. We're using the same even instruments as we do our procedures, so that the staff familiarity with them, with the instruments is pretty uniform, and our ability to move with ease. It's very important, I think, from a care delivery standpoint, to make the technology recede into the background as the patient care recedes into the foreground. And the technology recedes into the background when it's all uniform. You know, when the rooms look the same, when they feel the same. You know, everybody just kind of relaxes a little bit more because they're not worried about trying to understand the technology and apply it in a different way in a different room. And so room standardization, I think, is important, you know, where the console is in relationship to the operating room bed and into the, you know, to the anesthesiology partners that are there managing the patient. All these things are key little bitty points that we work on as we develop our program, so that we're decreasing the anxiety of actually delivering the care and making the technology recede in its attention as the technology performs in such a beautiful way, and we, you know, can focus on the patient care. I think that that's a real key element to standardization of technology.
I think the comment that resonated with me there too, right, is having all the physicians aligned in this and moving in the same direction just seems inherently powerful, honestly, in a kind of way that you can really approach this all together collectively. Thank you for that, Dr. Vigness. Dr. Burk, any additional comments there?
Yeah, Brian, you've heard us talk about the team and how the team works well together. But let me make a very unsolicited statement. The Intuitive personnel have been an important part of that team. They have been there. They have clarified the operation of the equipment, answered questions, either physically present or immediately available by phone. I don't think we could have moved as far as fast without the on-site support that Intuitive has provided. I can't say enough of how much that has helped and been important to the program development. And to the physicians in the audience, I would share one other thing. Don't try to do this without the absolute support of administration. This has been a true team effort and has taken administrative support. We have 2 nurse practitioners who are helping us in the pulmonary nodule clinic, who've set up a virtual pulmonary cancer conference that meets at 7 o'clock in the morning. So it has been a team effort, and that team has come together. It continues to fine tune and adjust as we have new experiences. but the patient has been the benefactor of all this. And we're delivering a level of care that frankly I never dreamed of in the decades past. And it's been exciting. It's absolutely exciting.
Thank you for sharing that, Dr. Burk. And I want to build on those comments around the team, right? And I think it's a recurring theme in this conversation, team, not just among physicians, but administrators and intuitive personnel as well. So Jennifer and Joseph, then, Joseph, maybe we'll start with you. Can you talk about how maybe you've evolved the structure and organization of your teams to support this strategy?
Yeah, I can remember the initial ideas of, we'll just take this thoracic lung program. You're sitting around in a room and thinking about programmatically, what do we need to do in order to expand this? And once we get the energy flowing and the physicians, the clinicians, the people taking care of the patient begin to guide and direct the conversation as they begin to point out the challenges and limitations that exist, then we start to add in all of the components, including bringing in team members from Intuitive. We were able to come up with solutions that really do put the patient at the center of the care. And so all of that energy only comes about because we're bringing the patient care experts to the table to walk through the journey that the patient that they have seen patients, many before, walk and confront limitations that due to technologies that weren't available to them. And through that discussion, we're able to come up with some very beneficial approaches to everyone involved, particularly the patient.
Thank you, Joseph. And Jennifer, can you speak to this this teamwork component as well?
Oh, definitely. Dr. Burk kind of stole my thunder. I wanted to give kudos to our team. We have a programmatic director as well as two phenomenal nurse practitioners that genuinely care for these patients. They engage with the physicians on multiple levels, a phone call away always, but genuine interest in the throughput and care delivery of these patients and ultimately their outcome and quality of life. So part of our evolved structure includes, as Dr. Burk said, the lung nodule conference in the mornings where they review cases. We also do case reviews prior to Ion, where the physicians to include cardiothoracic surgery and pulmonology, radiation oncology get together and discuss cases. And it's a robust conversation that includes all aspects, from the nursing aspect of follow-up care to how the patient's going to recover. And the physicians are able to debate, per se, to make sure that the patient's getting the right direction. And so it's very empowering. I will say that the nurse practitioners and the physicians probably can vouch for this as well, do excellent follow-up. They follow the patient through their hospitalization as well as post-op to make sure that overall the success and the quality of the procedure was obtained. So
thank you, Jennifer. It really sounds. Dr. Vigness, did you have quick comments there?
I want to make a point here. All this couldn't happen without great administrative support, but also great information technology support. It's amazing. We can pull studies in from outside referrals and have the studies, the DICOM images unified into a very brisk presentation by our radiology partners, who are the ones that do our needle biopsies. And that's what makes these presentations go so quickly. We'll go through 13, 14 patients in a matter of 50 minutes. Mm-hmm. And we couldn't do that if we didn't have great information technology. And all of us join this from our virtual positions wherever we are in our day. We just stop. This happens to be on my block OR time day for doing robotic surgery. And so once I get the patient checked in and we get started on the whole process of getting that operation started, then I can stop right there and join this conference. And we can look at all these images. We can have this robust multidisciplinary conversation and discussion about really what's the best thing for this particular patient. And then we have our nurse practitioners who are just magicians at leaping over barriers of getting the things done. It's just we've got a great hospital with just full of people who want to do the right thing, and these nurse practitioners help their colleagues do the right thing by getting these things done. And so it's a managed. We've managed to really put together quite a robust system for working up the solitary pulmonary nodule, which is the scariest thing that any patient can hear. And so the quicker that we can get to an understanding of what that nodule really represents and what a really big, several different disciplines of medical thought think about that pulmonary nodule. And if it comes to the actual delivery of procedural care, we can do it quickly. So I think that there's lots of unsung heroes here, and I want to bring them all up.
Important points, Dr. Vigness. I think the importance of teamwork at Texas Health Fort Worth is coming across clearly in this conversation. I think there's so many different moving parts here, but it seems like you've all collectively come together to make this work. Dr. Burk, would you like to build on those comments?
There's one team member we haven't mentioned that we shouldn't overlook, and that's the anesthesiologist. When it comes to the day of the procedure, they are crucial to be part of it and be thinking with you throughout the procedure. And we bring them on board before so that they know the case, but during the day of the procedure, they're just crucial to have understanding of the case and what's to come.
Thank you, Dr. Burk. Thanks for pointing that out as well. I think for the benefit of attendees, I want to ask all of you to weigh in on this next question. If folks out there listening are considering a move toward standardization, like the journey you all have been on, where should they begin in their analysis? Where should they get going? And I'm thinking here broadly about what data to consider, what stakeholders to include, financing options, the whole thing. So I want to hear from each of you on this one. Joseph, you want to start us off?
Certainly. The first place to look is to the caregivers. So where is the interest? Who is carrying the flag? Who is going to lead the charge? And the medical staff, you'll find no shortage in them, but there's going to be a leader who is going to assess the technology. He's going to put in the hours above and beyond where you are today to bring the solutions or ideas, at least, to the table in a way that casts a vision. And it's got to be done by the pulmonologist in this case, by the cardiothoracic surgeon in this case, but by those thought leaders on your medical staff who know what the challenges of patient care are that they see every day, that they're tackling every day. They're going to bring those ideas to the table, and then putting the team around them who can support them will really drive performance.
Building around your caregivers, really, really important point there, Joseph. Thank you. Jennifer, turning to you next, same question.
Sure. To add on to Joseph, engagement of caregivers that have been within the operating environment for quite some time. And so surgeons and practitioners, to grow them in this minimally invasive technology is one of our turning points at Harris Methodist Hospital. We have multiple surgeons that are engaging in the technology just as it is a method to improve overall quality of care. This is a special point to note that as we are on our academic journey with graduate medical students and surgical residents at present, teaching them the latest and greatest as to provide high quality care.
Thank you, Jennifer. Dr. Burk, you want to build on those comments?
Absolutely, absolutely. Historically, there may be a lot of competing interest in the care of cancer patients and the care of lung cancer. You identify those who are willing to be committed to the patient, who are committed to the quality of care and the outcome of that patient, and those are who you invite to participate to start with. If everyone is committed to that mission, to that goal of quality care for your lung cancer patient, it'll work out. everything else will fall in place. It's a mutual commitment to quality of care.
Important point. Putting the patient at the center of everything. You build around
Absolutely.
the caregivers, and you bring the patient considerations into every decision. Thank you, Dr. Burk. Dr. Vigness, what advice would you give to attendees out there?
Well, it's really true. If it's a patient-centric activity, then everybody's going to want to participate. Once you have the vision from administration to support this, then the practitioners I think you'll need is a good surgeon and a good pulmonologist who work together well. John and I worked together for the last 32 years, and we've dreamed about a program like this for decades. So we were ready. I made the transition to being a totally robotic surgeon, thoracic surgeon, about 2.5 years ago. With the support of the administration, I got the training. There were some gifted proctors who came and helped me get started. The robust support of Intuitive in making proctors available so that I could really kind of master the technology was great. So there's no shortage of support that Intuitive will bring to the table. And this gets back to this idea of having sort of a suite of technology that you can bring. I mean, the Ion technical support and then the Vinci technical support is really second to none. So once you have a good surgeon and a good pulmonologist who want to work together, and with the support of the administration, and we have a very strong oncology director. She's amazing, Kirsten Drake, and she oversees the 2 nurse practitioners that we're working with. And so we don't have any barriers. I mean, we just have a barrier of trying to figure out what's the next best thing to make this program work better, and we do it. And so it's getting better with each and every turn of the wheel.
Thank you, Dr. Vigness. Before we jump to audience questions, you touched on something there that I want to make sure we get to. So I'm going to put this question out there, and whoever wants to leap at it can. The question is sort of thinking about what you said there, Dr. Vigness. What is next? It's been a pleasure hearing about your all's journey on this road to sort of, really standardize and work together as a team. But curious, what's next?
I tell you, Brian, what has happened because of this success story, this has just amplified the energy to bring others in other service lines along. I think Dr. Vigness mentioned gynecologic oncology applications there, but in general surgery, there are several applications for use in that space, and we have had physicians bring ideas now that we had not heard of prior to us having such great energy and success in patient outcomes with this thoracic lung program. And so now we're seeing application to a center of excellence potentially in advanced hernias. We are seeing ideas come out in other hepatobiliary applications. And so I think what this has done is now given us an opportunity to sit down with some additional teams and begin to work out what will, I believe, eventually look like the success of the thoracic lung program.
Thank you, Joseph, and thank each of you for walking attendees through your journey, and excited to hear more about what comes next. So I really appreciate it. We've got just a few minutes left together, so I'm going to jump to some audience questions here. We've had a few come in. The one I'm going to put to the group is the attendee asks, are you seeing a shift in more patients seeking your minimally invasive care options in your market? How have you specifically marketed this bridge between Ion and Da Vinci?
I'll mention 1 or 2 things, and maybe Jennifer or one of the physicians can pick it up. I mentioned early in one of my comments that we've begun to receive referrals because of the outcomes that some of the patients have received in their communities. Physicians that we had not normally or historically had be a part of the program now sending referrals for their patients into the lung nodule program. The two nurse practitioners that have been mentioned a couple of times already have done a tremendous job of communicating. Once they get results or some kind of data back on those patients, they share that information immediately with those referring physicians and of course, anyone in that system when they receive immediate feedback, thorough feedback, are going to become partners, new partners to the program. And so there's been a lot of that happening, and we've seen volumes from historically underrepresented populations begin to grow.
Excellent. Thank you for sharing that, Joseph. Jennifer, either the docs, anything to add on before I jump to another question?
It's turning more and more into programmatic referral as opposed to individual physician referral. The people are referring, and people refer themselves to our lung nodule clinic, you know, and that is where I think the future is.
Excellent.
Word has spread, you know, it spreads, the word spreads, patients spread, but practitioners who've seen their patients go, oh, I have somebody else, let me see. They tell it to their partners, to the people that the other physicians they work with. You wouldn't believe what happened to my patient or how easy it was. This is, it's not a grass fire, but it is spreading on its own. We're keeping our nurse practitioners pretty busy with clinic and the workload in front of them. They would love to be out marketing, but basically they're not having much time to do it. We'll be working on that. And the other thing, Brian, this is our first, we have a year behind us. We're maturing. We're entering adolescence in this program, which is an exciting time. There may be a few missteps, but we'll get it right. And it's going to change, it's transformative of lung cancer care in our community. It absolutely is.
It has been a COVID year as well, Brian. It's kind of like dog years. So.
Yeah, been busy, I imagine, just a little bit. Excellent. And knowing that you're also so very busy, we'll take one more audience question before we sign off here. The attendee asks, how are you quantifying cost savings for standardizing?
I would just one comment. As this started to unfold, Dr. Vigness and I would sit down and talk about some of the early patient outcomes. And as he began to use the minimally invasive approach, we saw not just small reductions, and he can comment on that in the patient's length of stay, but a patient who stays here 3, 5, 7, 10 days less than they had historically is an enormous saving for the entire system, healthcare system. And that taken to the volume of patients that this approach can be used on across the country is an enormous saving.
I think that's a great place to end on. Thank you, Joseph. Thank you, Jennifer. Thank you, Dr. Vigness. Thank you, Dr. Burk. It truly has been a pleasure speaking with you today. And thanks to everyone in attendance. You'll now have a quick break before you get to your next session. Also, please remember to complete the survey at the end of our time together here. We're constantly looking for ways to improve. So thank you so much again for joining us.
Thank you.
Thank you.
Thank you.
Brian.